It's great when it works.
Okay,
so how do we want to do that? Do you start?
Shall I quickly start who I am? So I'm Tony Bayer. I ran the memory team in Cardiff for many years and was a Professor of Geriatric Medicine in Cardiff University. But I retired 2 years ago, and one of the things I've been doing since retirement is some involvement with Improvement Cymru and with this course, of which you're the fourth cohort. So there are about 14 or 15 people on each course, and we deliberately try and sort of the applicants sort of pick people to get a good mix. So sort of a mix of health boards, a mix of professional backgrounds, and that seems to work well previously. And so let's keep our fingers crossed it works well this time round. So that's me, Michaela.
Hi everybody. I'll just quickly wave to you all and then turn my camera off so that you don't see me coughing and spluttering. So I'm Michaela Morris and I work in Improvement Cymru, which is part of Public Health Wales. And I lead on the Dementia Care programme with a small team, Rebecca Hanmer and Ian Doverston. And we've got Tina Oakes, who's our programme support, and we've got Diane Davis, D, who is our admin support. So we're a small team. We lead on the Dementia Care programme. We would want you to learn a lot more about that programme happening in your regions. And the dementia faculty and this subsequent dementia diagnosing course is one of the arms that sits under that whole sort of regional approach to sort of trying to improve dementia care across the regions. And there are many other work streams. We'll pop the dementia pathway standards obviously in the Padlet that you're going to be using over the 4 days, and where you'll find your information for sort of future work. But also having a look at what work is happening in your regions. We'll put the readiness documents on there as well against all of the work streams that are happening in your regions. So suffice to say, I welcome everybody today, and we'll go round. Do we want to go round of the people that are on screen? I'm going to go in alphabetical order as it is on my participants list. So we've got Abigail. Is that Abby? Is Abby here?
Hi.
Hi. Do you want to turn your camera on, introduce yourself?
Yes, I will. My internet might be a bit slow.
On and off. It's the buttons are working, they're not working right today, are they?
No, it's not. I won't be able to turn my mic off even now. Sorry. So my name's Abigail. I'm a CPN and trainee advanced clinical practitioner, and I work in Llanystabrig in Llandudno with the older person CMHT. So we primarily do functional and organic.
Oh, we've lost Abigail. Abby. Are you back, Abby?
I think I'm back. Can you hear me?
You're back, yes. So you're in the older adult CMHT?
Yes, I am.
Lovely. And you're doing assessments and diagnosis in the CMHT of people presenting with memory problems. Is that right?
Yes, sorry, my internet's really poor.
There we are. No worries. You try and sort it out your end, and we'll move on. We've got Ailsa. Is that how you pronounce your name, Ailsa?
Hey, yeah, it is. I'm Ailsa. I'm an OT working in memory assessment service in our health board. Most of my job is post-diagnostic assessment and support from an OT perspective, but about a quarter of my work I'm helping to sort of diagnose people and get involved in that.
Lovely. Thank you. Welcome, Ailsa.
Thank you. Hi,
Angela. Angela Allen.
have to switch my mic on, wouldn't it? Yeah, my name's Angela. I work in Ceredigion for Howth Our Health Board as a specialist nurse for the Memory Assessment Service. So again, I'm assessing and diagnosing people with memory problems.
Lovely. Welcome, Angela.
Thank you.
Tony, we've had. Dawn?
Hello, I'm a memory specialist nurse working with the memory assessment team for the South Carmarthenshire, which is the Our Health Board.
Thank you, Dawn. And then we've got James.
Hi, I'm James. I'm a geriatric registrar. I'm currently just at the beginning in my ST4 year, but I'm working at the moment at Landoc. So I am gaining some more experience about assessment and diagnosis, and seeing where my career takes me from here.
Lovely. Thank you, James. Welcome. I hope you find the light. Thank you, James. Jane Green.
I'm Jane. I'm one of the nurses from the memory team at Cardiff and Vale. Used to work alongside Tony, so we do diagnosis and post-diagnostic support here.
So
Lovely.
this is going to be continuing education for you, Jane. You can see what's new that I can teach you.
Thank you, Jane. And then we've got Kirsty Richards from Swansea Bay.
Oh, hi, I'm Kirsty. I work in the Primary Assessment Service in Westford in Swansea, and again, I do assessments and diagnosis and post-diagnostic care.
Okay, is that Dr. Sangal's area?
Well, yeah, we cover Sangal works in one of our practices, yes. So then we've got Dr. Baker and Dr. Hill.
And you're in the primary care arm, and you're obviously seeing people very, very early doors for, yeah, lovely. Yeah. And that's connected into memory assessment services locally?
Yeah, they sort of, Swansea Bay did it a bit differently and have amalgamated our primary mental health services with our memory assessment services. So we see both basically for older adults.
Lovely. Oh, thank you, Kirsty. That's useful. Lisa?
Hi, my name is Lisa Johnson. I work for Swansea Bay University Health Board. I'm a CPN in the community mental health team for older adults, and we work primarily with older adults accessing primary and secondary care. We have within our primary service a memory assessment service, but we sort of assess organic and functional mental health conditions, and you know, post-op diagnostic care, utilising care pathways, liaising with other services within our area.
Thank you. Thank you, Lisa. That's going to be really interesting going forward, how we can see that supporting you being able to undertake the assessment and the diagnosis with memory assessment services. So I'm really keen to see how that works from a CMHT point of view.
Yes, yes.
You said you're from a CMHT, isn't it? Yeah. Yes,
I am, but under the mental health measure, within our service in East Talbot, we take assessments and carry caseloads of primary and secondary care individuals with memory problems and mental health conditions.
Great, that's going to be useful. Thank you, Lisa. Lisa Rutter.
Welcome.
Is it Lisa Rutter? Hello. Have I said that right?
Yeah, can you hear me?
Yes, can hear you.
Yeah. So I work within the primary mental health team in Bridgend in Cwmtaf. We're at the moment, as you're probably aware, because some of my colleagues have come through, and I have sat in on 2 other sessions that we're trying to align our service for a MAS service. So that's sort of where my speciality is.
Lovely, thank you. That's really useful. And then we have Naomi.
Sorry. I'm Naomi. Sorry, I'm in Vietnam at the moment, so that's why I'm in bed and it's dark. So you're wondering what a weird setup I've got. It's because yeah, it's night. But yeah, I am a pharmacist at Cwmtaf. I work in the Royal Glamorgan, and I've been covering the older adult wards along with the psychiatric admissions ward for the last about 3 years. But I've just managed to secure funding for an ESPA, which will mean that I'll be starting to conduct memory clinics alongside the consultants in the health board to try and sort of bring down the sort of backlog of patients that are waiting for a diagnosis. So I'll start off with just taking on the complex follow-ups that usually get pushed on to the consultants, and then with time hopefully help with diagnosing as well with experience. So yeah,
that's lovely. Thank you. That's really interesting. That's another interesting area to explore, I think, with this. So thank you, Naomi, all the way from Vietnam. And then we have Sophia.
Hello, I'm Sophia. I work in psychiatric liaison, primarily in older adults, in Wrexham, in Betsy Cadwallader University Health Board. And I finished my Dementia Masters in January. So I suppose it is a bit of a sort of add-on to that, and to continue to improve my knowledge as I'm sort of working towards consultant dementia nurse. But in the flip side of that, I've also got a new job. So halfway through this, I'll probably be switching to a new job. So it'll be interesting to sort of see it from 2 different sides. But still with older adults. So
that'd be interesting. So you can tell us.
Job is.
Yes.
Oh, I've got a job as the ward manager of Hudref Ward. It's a older person's functional ward.
Right, okay. So again, you'll be primed to be able to maybe spot some early signs and even undertake some assessment and diagnosis from that side of things. So that's going to be interesting as well to see how that works. That's everybody I've got on my list. Have I missed anybody out that's actually on the call? I think that's everybody here. So we're missing Victoria Davis, Amanda Aston, Hilary Ryan, Magdalena Ilgoska, I think her name is Magdalena, James Larriman, and Naja Adnan.
We've got James.
James, we've done James.
Yeah.
We've done Naomi and Raja Adnan, is it?
No, well, Raja's talking after me later.
He's talking after. There we are. So we've done everybody then.
Yep.
That's lovely. So where do we want to go now? A bit of a background just quickly as to how we got here.
Absolutely. Do you want to start making it, Michaela, and then shall I take over?
I'll just quickly say how we got here, and then Tony can take it away, really. Basically, before the pandemic started, we were having lots of workshops, meetings all across Wales to try and take forward the dementia pathway of standards. We were having meetings that were looking at shaping what the data set would look like for memory assessment. Everything was co-produced. So we had lots of people from workforce, lots of people with lived experience, lots of third sector agencies, all involved in our work. One of the conversations we had was, and we're having and still having, around the flow through memory assessment services, or the flow through the whole journey, rather than just memory assessment services for the person. And that shaped our dementia pathway of standards. And of course, in those conversations, we were looking at, so, you know, what happens when somebody goes along to the GP, or where do people go along to talk about their early concerns, really, about their memory? What happens when they get to the GP? What happens, or how do people access memory assessment? What happens when people go into hospital, whether that's a general health setting or a mental health setting, and they have dementia? What happens if people go into hospital and they don't have a diagnosis of dementia? What and how happens for that person, and how do they get involved in getting the right assessment? and get on the right pathway so they can get the right interventions early enough. So loads of conversations here. Also, the Welsh Government were working with us, issuing the read codes where the diagnosis is captured and then communicated to the GP practices so that it can go on the dementia register. So those pieces of work were all started. We managed to continue a lot of them through the pandemic when we first went into that first year of lockdown and everything. But one of our conversations, and I think this was just before we went into lockdown, was about, well, who diagnoses dementia? Who undertakes the assessment? And have we got a consistency around a diagnostic assessment? And we very much started talking about, well, you know, there are many disciplines that can undertake assessment. There are many disciplines that can provide a diagnosis. And we talked about different courses. There are courses available that can sort of support people to be able to do this. But actually the guidance says that, you know, as long as you're a competent clinical practitioner, you can undertake these functions. So that led us to talking to Tony, where so I think it was, I can remember turning around in Riverhouse in Cardiff and saying to Tony, well, why can't we create our own course? And Tony's response was, there's no reason why we can't. And so that's where that got us on this journey of thinking about what would this course look like? How do people get on it? And what could you be doing and regions be doing and we be doing nationally to be able to support the people that come along to this type of course. And that led us to think then about the dementia faculty and having everybody connected into a dementia faculty so that we could provide ongoing education, learning and development for people who are in this space of no matter where they're setting, where they have an opportunity to assess and diagnose. So we've had fits and starts of this course because of the pandemic, the winter pressures, although those winter pressures now seem to be all year round pressures because of what everything has brought to play in sort of affecting how our services are running and the workforce and the landscape and shortages and all those kinds of things. But we very much are starting to, with Cohort 4, bring it back on track with you guys and ladies, I should say, about bringing that back on track and sort of robustly looking at what this course can look like going forward, how we can really get it into play, into practice, so that we've got timely diagnosis being provided and we've got all practitioners able to provide a diagnosis following working with their multidisciplinary team in assessment and formulation, so that we can get that diagnosis given in a timely way. So there will be a couple of things that we will want from you, obviously, to be connected into practice, have your mentors there, and we'll take you through more of that really as we go through the 4 days so that you're very clear about what you need to be doing yourselves back in your workplace in between these sessions and following these sessions. What we've done to date is bring the first 3 cohorts back together to have a little bit of touch base with them, because as I said, things have sort of got a little bit fragmented because of the service pressures. And Tony, I'm sure, will update you on some of the things that those 2 sessions of, you know, the information they've given us. Everybody who came along, he's just informed me before we came on the call today that we do seem to have quite a positive outlook from the people who have done the cohorts before, that it's shaped their practice and they've been able to utilise that learning to be able to support memory assessment in their aim of giving people a much better experience and a more timely experience. So I'll hand you over to Tony, and because my voice is going to pack in any minute, but that's enough from me anyway, I think.
Great. Thanks very much. Okay, well, yeah, that's the background. In practice, what I guess you have already realised is that you're a very sort of mixed group with mixed experience, mixed professional backgrounds, geographically mixed. And as I say, that's deliberate, partly to actually not turn it into a sort of too much of a clique, but also so that we can actually also all sort of come from different perspectives and learn from each other. So one of the things I'd ask would be, you know, as we go along, and I think all the speakers are happy to be sort of interrupted as they go along, questions. So just the easiest way is to raise your hand, and then you can be sort of brought in, or if you want to sort of make a comment or a point, you can obviously put it in the chat. The Padlet does, I don't know if you've all accessed it yet, but the Padlet will have the slides on, and it's got other relevant information, papers, copies of useful material, really, that hopefully can help you with sort of day-to-day work. So if Sue, if we can go for the next slide, if you're in charge of slide. Yeah, so very quickly, this is the sort of rather long strap line. So we're going to build and maintain this cohort of clinicians within Wales. It's not to you know, obviously Wales does have different background, different sort of responsibilities government than England. So that's why it's specifically sort of Welsh tailored. So could we make the slides any bigger? My aging eyesight has difficulty, and I know I'm by far the oldest, but it might make life easier for other people.
Well, yeah, so you can control that from your end, Tony. So if you click on the three dots in your menu,
yeah,
and it brings up a long list, and halfway down that list it says focus on content.
Yeah, it doesn't bring up the list actually, it just because the presenters turned off participant navigation.
Okay, so I've taken that off now. So okay, if you click on your three dots.
I'm afraid I'm still just getting viewing how I view slides or translate.
Right, so it's on your menu and it's called More. Three dots and it's called More.
Yeah, no, I've got the three dots, but it's okay, so I've got navigation, so I've got
yes, it's not on the navigation pane. It's kind of at the top where you've got your chat and your reactions.
Yeah.
And then it says More, and it should pull up a list of things you can do from your end.
Yeah, just nothing's happening with. Oh, what success! Wait a minute. So if I go to full, so I've gone to full screens, which hopefully has made it bigger for everybody.
Yeah, that's individually accessed by each person on the call. So for you, it will be full screen. If others want to have it full screen, then they can also click on their More menu option and click on the full screen option.
Okay.
There's also the focus on content option that lets you still see the chat, which is the one that might be useful if you want to put some questions. Although I think, Tony, we would prefer you to raise your hand and talk through some of your queries or questions for Tony.
Okay, so I'm focusing on content now, so if I carry on and people can be playing with the controls to find something that suits them best as I talk. So yeah, so really the aim of Wales Dementia Faculty is obviously to raise awareness, particularly focusing on diagnosis and management. So really to have active clinicians, which all you lot are, and to try and get much greater equity across Wales so that we don't have the famous postcode diagnosis or postcode prescribing. One of the things, unfortunately, that still distinguishes Wales from the other countries in the UK is that our dementia diagnostic rates are lower, and so we equally want to try and raise dementia rates, but in a sort of a useful, timely way that's going to actually benefit patients and carers and the professionals looking after them, rather than just sort of, I know, massaging the statistics to look better. And generally that you feel confident with what you're doing, that you can sort of feel able to stretch yourselves, and you've got colleagues that you can do it to discuss things with as well. So we've got this training course. The clinical practice sessions are for you to arrange, and what we would like you to do is between now and the next 3 sessions is to actually arrange opportunities to go and spend time, sit in on perhaps a memory clinic with your mentors. If you are perhaps very embedded in a memory assessment service, perhaps go cross-border and go and to another health board and find out how they spend their time sitting on a memory clinic, sitting in on some patient assessments, to really just get a broader experience. Each of you are going to have, you know, a lot of skills in one particular area, perhaps less skills, less experience in other areas. So this is an opportunity for you to go and plug the gaps. If hopefully you can, via your mentor, you can arrange opportunities locally. If you want to go to a service in an adjacent health board, but you don't know who to contact, well, if you contact Michaela or you contact me, we can hopefully oil the wheels and make the introductions there. So observing other people's clinical practice. One of the things that we would hope that would be an outcome that you would undertake after these initial training course is perhaps getting involved in some local quality improvement program yourself and conducting those, and Michaela will talk about those later. And then the sort of regular update meetings that we've talked about, and the information Padlet. So that's what's going to be available. So next slide, except now I'm in charge of slides, aren't I? So I'll push the button. Okay, so this is basically the layout of the 4 sessions. So session 1, we are really sort of thinking about the evidence, and a lot of this will be pretty familiar to most of you, but I don't apologize to going back to basics, so that hopefully we all start with a common bunch of knowledge. And then when is it, next week, start looking at perhaps some of the extra assessments in more detail. Is use of neuroimaging, and when perhaps neuropsychology, OT can be useful. And then next month, more about good and bad practice in telling diagnoses, and what are the priorities really after the diagnosis. And then the last session, perhaps some more sort of talking about the subtypes in more detail, and particular, of course, all the people that we see with cognitive problems or cognitive plaints who don't have dementia, because just telling the good news is you don't have dementia but go away isn't very helpful. It's still a big problem for patients and relatives, and so we do need to actually think about how we manage people without dementia. So that's the background of the course. Anybody got anything they want to query or raise or highlight at this stage? Put your hand up or speak up, or otherwise I'll take silence as a no and quickly move on to why we're running the course. Now, this is pretty familiar, I guess, to everybody, that numbers of people with dementia in Wales is increasing, as it is England, UK, Europe, worldwide. In Wales, because Wales has a particularly elderly population, the increase in numbers is particularly significant. So over the next 20 years, so that's over the next sort of professional life, and most of you, we've got about a 60% increase in numbers expected. Michaela, I can see your hand up.
I'm just wondering, Tony, am I synced with the right slides at the minute on the screen? What slide have you got?
It should say
got
projected number of older people living with dementia in Wales.
No, I don't have that. I don't know what's wrong with mine. If I sync to presenter. Oh, there you are. I'm on it now. Lovely. Thank you.
Yeah, so Tony, if you're moving your slides on from your side, it's only moving them on for you. So if you could just say to me next slide, and I'll move them on for everybody else.
Yeah, that would be much better. Great.
Lovely.
Yep.
Thanks.
Okay, we'll yeah, shared responsibility is always best. So okay, so this is the slides that I was talking with the numbers over on the left that we're sort of expecting over your professional lives. So if you do actually focus and have a particular interest in dementia, you're certainly not going to be out of a job at any point, because 60% increase, and the sort of figure over on the right makes the point that nearly all this increase is going to be in the very old, the yellow bar, the over 85s. So there's really the number of people with dementia under 75 is going to stay broadly the same. It's the very elderly where the numbers are going to dramatically increase. And of course, it's the very elderly who don't just have one morbidity, they don't just have dementia, they also have other things wrong with them. And so they're also perhaps more likely to be frail, arthritis, sort of all the common problems of old age. So a sort of a service that focuses on dementia and ignores everything else, or services again that ignore dementia, aren't really going to actually be appropriate for the they're not appropriate now, but they're certainly not going to be appropriate in the future for the sort of patient mix, the case mix there's going to be. So next slide, please. The other thing that obviously COVID has impacted on all of us. Now, people with dementia are obviously the group who had the highest mortality from COVID, but it tended to be the people with advanced dementia who died with COVID disproportionately. And so in a way, they're rapidly being replaced by new cases. The other thing that's slightly unknown is whether COVID itself is going to have an impact on on numbers. There are lots of theoretical reasons why bad cases of COVID, and I've just realised this very tactless conversation to be having at the moment, in that Michaela is just recovering from COVID, but fortunately she's doing very well, and so I don't think it is going to particularly apply to her. But there are lots of reasons why COVID may have an impact, and if we go to the next slide, there is some emerging evidence that in fact COVID survivors do actually seem to be at greater risk of subsequently developing dementia. The sort of middle figure, the figure on the left there, the red line is the sort of risk of developing dementia in the months following COVID. The blue line is risk of developing dementia in the months following other non-COVID upper respiratory tract infections, so flu and things like that. So COVID does seem to actually have some impact on subsequent dementia risk. The graph over on the right is really looking at people who had particularly severe COVID, as highlighted by whether they developed delirium at the time of COVID or whether they were hospitalized or not. And if you had COVID and you had associated delirium, or if you were hospitalized with COVID, certainly there seems to be a quite significant increase in risk, perhaps 2 to 3 times risk of developing dementia. So, you know, our guesstimate numbers of over the next 20 years may in fact be an underestimate, courtesy of COVID. Now, next slide. The reason why Welsh Government is particularly interested and exercised by this is that the increase in numbers translates to an increase in cost, and the estimated increase in costs is over 100%, and that is predominantly, as we all know, in social care. So dementia certainly is going to have a very big impact, and given the current economic state of the country, that's particularly bad news. So we need to manage dementia as efficiently and as effectively as we can, which means we really need to recognize people with dementia. And the next slide is breakdown. You can sort of, each of you can sort of focus on your own health board. The blue line is the estimated numbers of people with dementia within the health board. The orange bar is the number who actually have a diagnosis within that health board. And in every single health board across Wales, it's round about a half of people have a diagnosis, and 50% simply don't. And it's very difficult to effectively manage a condition when half the cases aren't even diagnosed. Hence why it is important to actually increase and make us much more efficient at making the diagnosis in the first place. The reason that Betsy Cadwaladr has, say, far more patients with dementia than Powys is simply, of course, because the number of people who live in Betsy is much higher than number in Powys. If we go to the next slide, this is again, you can focus on your you can focus on your sort of individual health boards. These are figures, those are figures that were available before COVID. Obviously, we don't, what's happened since COVID, the figures are still being crunched. We have been improving, some health boards improving at a faster rate than others, but we still, over on the right-hand side, the Wales figures still far less than in Scotland, England, Northern Ireland. Certainly in England, the diagnostic rate after COVID has fallen down into by about 5 or 6%. So is now down in the about 60%. So it's reasonable to think that unfortunately the Wales diagnostic rate, which was at about 54%, will also have dropped by about 5 to 6%. So we're down to, likely to be down to under half of cases being diagnosed. And next slide, really, therefore, underlying policy over on the left and the Dementia Action Plan, which is now, I think, 3 or 4 years old, but more recently, the All Wales Dementia Care standards. One of the themes is increasing rates of formal diagnosis, making sure that people have a generally positive experience. It doesn't matter where in Wales you are, you get the same positive experience, and then appropriate interventions rapidly follow the diagnosis. So it doesn't matter who makes a diagnosis, where it's made, and the information, education and skills training is available for everybody. So that's really the policy background and numbers. So again, if I just pause at this point, and any comments, any questions, any thoughts from anybody?
Where do you get the diagnosis? Oh, sorry.
No, go for it.
The point about yeah, wherever you get the diagnosis from, having the same sort of outcome is interesting. Sorry, I'm not sure if my laptop's working or not.
No, it is. You no, it seems to be working, but you just broke up for a minute. Just try saying it again, and we can probably all hear you. Or not. If you can still hear me, probably maybe the easiest will be to put it in the chat then if the microphone isn't working. Can I quickly ask, I've been talking about equity of the importance of timely diagnosis, and just a quick run around out of interest. If I was concerned that I had dementia and I went to my GP today and he referred me to my local memory assessment service, how long would it take before I was seen with it locally within each? I don't know if people want to come in with how many weeks their waiting list is at the moment. How long? Yeah, go for it. So 2 to 3 months. So we've got 10, let's say 10 weeks. Any advance on 10 weeks with MD's waiting list? How long is the waiting list in Cardiff at the moment? So yeah, so we've got from, we're assessing. Can I just ask, there was who is it? I can't multitask it. So we've got we're trying to assess. We see, here we are, Kirsty, you're saying we see all patients within 4 weeks.
Yeah.
Can I just ask, but how long is it going to take before I get a diagnosis?
That's the difficulty. It depends on it. Sometimes the doctors run quite quickly, so we see them for assessment within 4 weeks, and quite often then it's about 6 weeks after that that they might see a doctor.
Okay, so
it's not. I wouldn't say it's overly long.
Yeah,
so we see them within 4 weeks.
Yeah, it's let's say, so it's about sort of 8 to 10 weeks before we get a diagnosis. And I guess you and I can say this as a medic, it questions what added value the doctor is always going to give to every single patient over what you've already done.
So we have started with some patients. So if we discuss it in the MDT, and it's you know, if someone's got a vascular dementia and we don't feel they need to see a doctor, then we as nurses will go out, and I guess with the, you know, that's the point of this course. So we will go out and see someone and deliver that diagnosis to them at home instead of having to wait for the doctor. So that does help, and we're doing that more frequently now.
Which is absolutely, yes, it's exactly the point. I think I could just, Lisa, I think you've got the record at the moment with saying that the diagnosis can take some case up to 9 months, and that's following assessment.
It depends what we as a team will receive the referral. We're seeing patients within 28 days, either at home or clinic, to do the assessment. Then when we take it through to the doctors, we've got 2 doctors in our area, and one of them, I mean, I think they're diagnosing people that I assessed like last December at the moment, December, January. And then one of the other consultants are probably within about 3 months, 3-4 months. So there's a massive difference between what area of Bridgend you live in. Okay,
and not to sort of start personalising it or make it more difficult, but if I was, you know, if I'm the patient who is concerned I might be developing Alzheimer's disease, you know, and I remember the way, you know, my mother went and all the rest of it, and I'm very concerned about it, it does seem somewhat unreasonable to be waiting for 9-10 months before either my mind is put at rest or I get a firm diagnosis. So so there's sort of, I think some people were saying sort of round about 28 days. Other people, it's considerably longer. So what we want to do is get, you know, it's not beyond the wit of man or woman to get a system where people are assessed, you know, pretty quickly within 2, 3, 4 weeks, and then that assessment ideally is a sort of one-stop shop in many cases, but then there is really a sort of minimal delay before the information is given and we can move on.
Tony, I'm just looking at Naomi Elias, 9 to 10 months for a formal diagnosis. There's another one as well that's 9 to 10 months. Can't remember, Naomi, where you're from.
So I'm CTM as well, but I cover so I'll be doing like Rhondda and well, it's not Bridgend, so Bridgend is like the other ILG within our thing, so we're all kind of in the same boat, but that's kind of how
so more North Clontarf.
Well, no, and Taff, so that's
Really?
sort of Pontypridd way as well. They've got quite, so the 9 to 10 months was when I last submitted my SBAR, which was about 3 or 4 months ago. So the way that I was going, it's probably actually higher than that now, potentially even longer. But like I was saying, the SNPs see the patients really quickly within about 4 weeks, but then they obviously then the patients don't get the formal diagnosis, and unless they have the formal diagnosis, then they're not open to sort of any, the families aren't open to any sort of group community help or anything either. So they're kind of just obviously sitting ducks, and like, as we know, a lot of GPs won't start them on the anticholinergics. Well, a lot of GPs wait for a consultant to diagnose them, so a lot of the time they're not having medication either, which is why that was like one of the main reasons I'm going to be obviously hopefully going to take up the complex follow-ups off the consultants so they can start diagnosing more patients every week, is the plan anyway, but we'll see. Hopefully that works.
Michaela.
Yeah, not for going in for now, because I know you need to move on, Tony, but I'm just wondering if everybody could have a little think about their own area. Are you aware that there is any work, so it's a yes or no, is there any work happening in your own memory assessment services to look at redesigning the pathway, re-looking at the pathway, looking at how things are needing to change so that some of these bottlenecks and blockers and barriers can sort of be unpicked and then moved on? So do you have like an action plan or an implementation plan to look at that? Not for answering now, but we could come back to that maybe. And if you don't and are not aware, maybe go away and find out between today's session and our next session, just to see if making those changes, those robust needed changes to the pathway are actually being addressed by your own service. So that would just be an ask from me. Thanks.
I think, and if they're not, there clearly is a need in all areas really, because there's the backlog from COVID that is adding to the waiting list. There's the increasing numbers just by demographic changes. There's increasing numbers due to greater awareness. So unfortunately, so waiting around for numbers of referrals to drop off isn't going to happen. So unless we do sort of change the way we approach things, the waiting lists are just going to continue increasing, which is why there is a need for more people to feel able and skilled to be able to recognize and diagnose dementia and get on and do something about it, rather than there being this sort of bottleneck that's actually getting increasingly tighter with getting people into memory assessment services. Okay, if we can just go to the next slide. And the slide after that, yep. So the sort of, just the next half an hour, 40 minutes before we have a break, I'm going to probably 50–60% of what I'm going to say is going to be known to most of you. Hopefully there'll be new things for all of you to learn, but just so that we actually are pretty clear about terminology and what we are aiming to diagnose and do something about from the outset. Now, fortunately, I think people clinically talking about people sort of with the fairies and having a screw loose and so on is just, in a way, not accepted language. The word confusion is still knocking around as if it's a diagnosis. And one of the things I've always said to the medical students is if you can sort of try and remove the word confusion from your vocabulary and instead use other words, then that will always help. Be specific about what the symptoms are, rather than just saying that somebody is confused. So are they forgetful? Are they disorientated? Are they deluded? Immediately starts helping. And then thinking, does this person have dementia, or and if so, then what is the likely underlying pathology or subtype of dementia? Now, if we go to the next slide, does anybody want to be brave and give a definition of dementia? Otherwise, the risk is I'll pick on people. Nobody's going to be brave, which, seeing everybody agreed that they were working and they saw people, lots of people with dementia. We've come on a course about dementia, but it is it's always the odd thing that whenever I ask people to actually come up and give a quick definition, there's always a hesitancy, which suggests that perhaps we're not quite as clear about what we're dealing with. So nobody brave enough to have a go at a definition of dementia? Yep, a collection of symptoms. Yeah, any particular symptoms? Do you want to come on and try talking to it?
Yeah, no, I just always think dementia is a collection of sort of symptoms that impair your ability to sort of think, make decisions, that sort of thing.
It is, but then I suppose I'd have to challenge that by saying, if I've had too much to drink.
Yes, that's true.
And I'd have to say, well, if I have delirium, or if I have learning disabilities, or if I have a head injury. So it's coming an umbrella term for a number of diseases. Yep, it's certainly what it is it's a description, it's a syndrome, and a definition of a syndrome is a collection of symptoms. So it's not a disease in itself. It's a description. Yeah, I think you're sort of getting there. So it's an umbrella term to describe progressive decline in cognition and function. Yeah, affecting the brain. Okay, let's go to the next slide. I know it seems very, very basic, but in a way, we do have to be absolutely clear in our own minds about what is and is not dementia, or otherwise very clearly we can't go and diagnose it. So it's an acquired syndrome, so we're not born with it, stating the obvious. So that's going to distinguish it from learning disabilities. And as I think knows as people, it requires a change in cognition. So that often includes memory, but can also be language, thinking, orientation, visual, spatial skills, whatever. So a change in cognition, and that's going to be sometimes the person themselves is going to notice the change, but perhaps more often it may be people who know them well, so an informant or clinician may notice the change. There has to be objective evidence of cognitive impairment, which implies that we have to go and formally assess their cognition, and strictly it has to be in 2 or more areas of cognition. And the bit that nearly everybody always forgets is that change in cognition has to be so significant that it interferes with day-to-day functioning and loss of independence, and clear consciousness. So that removes the fact that I haven't had a head injury, or I'm not drunk, and long duration. So change in cognition, severe enough to impact on functioning and fully conscious and certainly there for at least a couple of months. So if there is, in a way, one slide to think about and to, I know, print and stick up on a notice board above your desk, this is probably the one, so that we're all absolutely clear in what is and is not dementia. Now, actually, just looking at that definition, I would say that it didn't require a consultant geriatrician or old age psychiatrist or neurologist to actually make that diagnosis. All of us are just as competent and capable of actually working out whether there is been a change in cognition and a change in functioning, and we can actually administer some sort of cognitive test. So actually identifying dementia is not really a major issue. Just also, I can see that you're just asking for, yeah, everybody's presentations are going to be on the Padlet, but I'm afraid after the session, mainly because we found if people actually have the presentations before the session, then it has been known for people not to bother to turn up. But they will all be there afterwards. Okay, next slide. Now, just to be looking ahead, DSM-5, the Diagnostic and Statistical Manual 5th edition, which is the American Psychiatric Association way of classifying conditions, and it has also been taken up by ICD, the International Classification of Diseases, not the 11th edition, which is the one that we tend to use this side of the Atlantic. Both of them have sort of, well, tried to do away with the term dementia and are now, instead of talking about dementia, they're now talking about major neurocognitive disorder. Now, this is something that has just come in the last 2 or 3 years. It has already permeated into the research literature, and so people are talking about major neurocognitive disorders rather than about dementia. It is likely it is going to permeate into clinical practice, but probably it's going to take 5, 10, 15 years to do it. But if you want to be very modern, then you can be talking about major neurocognitive disorder rather than dementia. At the moment, of course, nobody will know what you're talking about on the whole. So it's best probably to stick with the terminology that we're familiar with. And the definition there is exactly the same. So a significant cognitive decline interferes with independence and not attributable to another mental disorder. So there's no difference between them. Major neurocognitive disorder perhaps is a bit of a broader concept. And there's also mild neurocognitive disorder. Next slide. Now, in old terminology, mild neurocognitive disorder was known as mild cognitive impairment. So that tends, or MCI, that tends to be what we talk about now. And mild cognitive impairment is also an acquired syndrome. It also concerns change in cognition. There has to be objective evidence of this cognitive impairment, but the difference between dementia is that it is not so severe that it affects independence. So there may be some subtle changes, but on the whole, people can compensate for the cognitive impairment pretty well. So MCI may be a stage that leads on to dementia or not. And the next slide, just to put that in a sort of cartoon, there's this idea that really there's a progression starting with healthy aging, and then people being more aware of a feeling that their cognition isn't quite so good, so subjective cognitive impairment. And I would say I'm at that stage at the moment. The next stage is where there is some evidence that people actually do have a mild degree of cognitive impairment. So that's MCI. And then if that becomes more severe and starts impacting on activities of daily living, functional impairments, well, then we have mild dementia, moderate dementia, and so on. And that duration from somebody having the very earliest signs to somebody having severe dementia happens over perhaps 20, 25 years. So on the whole, we only see the last 5 to 10 years of this this process. We don't see people in the very early stages, although the trend, of course, is for people to present earlier. There is increasingly a focus on certainly the mild cognitive impairment stage, and that's partly because the thinking is if we could delay the transition from MCI to dementia, then obviously that will benefit individuals greatly and also have knock-on effects for benefits to everything else. So next slide. Yeah, I think also tries to make the point that instead of having solid lines between these various stages, they're broken lines, because the distinction between subjective cognitive impairment and mild cognitive impairment hinges on being able to show that somebody underperforms on some cognitive test. Now, I was saying that I would consider myself in the subjective cognitive impairment stage at the moment, but I'm sure if somebody actually did run through a whole very detailed battery of cognitive tests, there would be at least one test which I might not do very well in, if nothing else, because I was bored with the number of tests that were being underdone, or my concentration lapsed, or whatever. So the distinction is difficult at times, and even more so between mild cognitive impairment and mild dementia. When we decide that functional impairment is significant and when it's not. I occasionally sort of mislay my keys and can't find them. Yesterday, I went to Tesco's intending to buy a couple of things, and I got the milk and I got the cheese, but I can't remember, I forgot the eggs or something. But I would regard that as sort of just everyday forgetfulness rather than being particularly indicative of a major problem. But it's a matter of judgment. So there isn't this rigid distinction in practice between each of these stages, in the same way that one person may regard a dementia as mild, whereas somebody else may regard it as moderate. If in doubt when diagnosing, it's probably better to go for the more conservative option. So rather than telling somebody they have mild dementia, it's probably better to actually say, well, at the moment this seems to be mild cognitive impairment, but it's important that we follow you up in future because these problems can sometimes deteriorate. Not all MCI, of course, changes to mild dementia. About, depending on what study you look at, 40–50% of mild cognitive impairment never progresses, and in some cases, in fact, improves with time. So MCI isn't inevitably heading towards dementia, but in about 50% of cases, it will change into dementia. Any questions, any comments, any thoughts at this stage? Let me go on to the next slide while everybody's thinking about it. No, okay. So if we're thinking about a diagnosis, there are really two steps. Step one is, what is the syndrome? Is it dementia or major neurocognitive disorder, or is it MCI, or is it subjective cognitive impairment? And that is going to be determined by whether there's objective evidence of cognitive impairment and whether there's significant functional impairment. Next slide. There's other syndromes that are going to present to us. So people who are very concerned about their memory, but have a sort of functional cognitive disorder, there's no objective evidence of problems. Obviously, people with major depression, schizophrenia, what have you, may have cognitive problems, and then lots of other things, head injuries and vitamin B12 deficiencies and sleep apnea and so on and so on. But those other syndromes are going to become apparent from you taking a good history and doing the assessment properly. Next slide. So if we think of dementia as an umbrella sort of term, then next slide, underneath the umbrella is all the various potential causes of dementia. So this is step two, which is what is the underlying disease or biological abnormality that is responsible for the dementia. And Alzheimer's disease on the left is going to be the most common, and then Lewy body disease and frontotemporal dementia, the other common neurodegenerative diseases, and then the vascular dementias, and then lots of other sort of uncommon small print conditions. And next slide. Now, every memory service is going to be different. This is just happens to be the breakdown of the memory clinic diagnoses going back 5 years ago in Cardiff. So of the 1,370 new diagnoses made in 2017, Alzheimer's disease was by far the commonest diagnosis, followed by mixed dementia or vascular dementia, and then Lewy body dementia, frontotemporal dementia uncommonly. About 1 in 8 of the patients referred to us about 5 years ago were mild cognitive impairment, and a slightly larger proportion were all the other things like alcohol, which was quite a significant issue, functional problems, psychiatric disorders, the occasional tumour, and so on. But that's the sort of fairly typical breakdown that you get of the subtypes of diagnoses. And next slide. If we think of the terminology that's used for these dementia subtypes, and nosology is a good Scrabble word for it. It means medical terminology, the origin of medical terms. The problem is that, again, the terminology is very, very confusing for this, looking at the causes of dementia. Next slide. Eponyms are where a condition is named after somebody who first described it. And Alzheimer's disease, I guess, is the most typical, obviously the commonest dementia subtype. But there are various other cause of dementia that again are named after the person who first described them. So this is, I'm afraid, when we go interactive again, anybody well, first of all, anybody wants to tell me which is the picture of Alzheimer? And then anybody else want to tell me who the other pictures are of? Also, you're going to
Sorry, I don't think it was me, unless I've done
well, okay.
something.
Unfortunately, your hand went up. So who do you reckon? So I'll push you anyway. Who do you think is
Okay.
Dr. Alzheimer?
I want to say bottom left, but I'm just guessing.
Yeah, you're nearly there. It's bottom row. It's the second, the bottom row, second one in, the man with the monocle. That's Alois Alzheimer, who described Alzheimer, who described the changes under the microscope that happen in Alzheimer's disease. So the plaques and tangles, the amyloid protein, the tau protein. He first described a case of Alzheimer's disease in 1905. Any suggestions who the other people might be? We've got a suggestion for James Parkinson, top right, a name under the photo. Yeah, very well observed and very good eyesight. Unfortunately wrong. The name is there as the deliberate one to see if people are alert. In fact, I'll tell you for free that all the 4 photographs on the right of the slide are all of James Parkinson. And they are all from the internet, but they're all the wrong James Parkinson. None of them are the James Parkinson as in Parkinson's disease, because there is no picture or photograph of James Parkinson of Parkinson's disease fame. So all the ones on the right are just there to confuse you. Yeah, we've got a suggestion of pick. So that leaves 3 people who might be pick. Do you want to suggest which one? We could have a vote. Who looks the most like Professor Pick? Top row, second one in. Yep. He. I don't know whether that was because he looks the part or whether you're actually. Yeah, that's Arnold Pick, who again described the pathological changes in Pick's disease in people with what we would now call frontotemporal dementia. So he described cases of, he called it circumscribed atrophy, where the atrophy was localized to the frontal lobes or the temporal lobes, and subsequently called Pick's disease. And we've got Jane coming in and correctly identifying Frederick Louis, top left, as in Lewy body, or if we're going to be pedantic, Levy body. Again, the pathological changes that you find within the cell, not just within in Lewy body dementia, but also exactly the same pathological change you find in the cell in Parkinson's disease. And interestingly, he worked in Alzheimer's laboratory in the early 1900s, and that was where he first described the Lewy body. So that leaves the bottom left. Any sort of eponymous cause of dementia? Used to be particularly common in the Neath Valley. Yeah, we've got a guess of Huntington's or Korsakoff's. I'm not sure whether, well, Korsakoff's is probably pretty common in the Neath Valley too, but it's actually Huntington, as in Huntington's disease. Now, I'm not going to talk anything more about Huntington's disease because it's obviously tends to be an uncommon cause of dominantly young onset dementia. And in Wales, there is a very active Huntington's disease service set up, and so the very few people with Huntington's disease tend not to come to memory assessment services. And because it's a familial condition, people unfortunately tend to diagnose themselves because they know that other relatives in the family have developed Huntington's disease in the past. So that's the only mention we're going to have of it. So that's the eponyms for dementia subtypes. If we just go to the next slide. Yeah, James husband, none of the real one. There we are. And the next slide. Now, some causes of dementia are actually really descriptive term based on their symptomatology. So people talk about primary progressive aphasia, which is exactly what it is. It's a progressive language problem that is a primary condition rather than be secondary to something else. It's another way of calling primary progressive aphasia is it's a form of frontal temporal dementia. Frontal temporal dementia in the past has also been called Pick's disease. So they're not different conditions, it's just different terminology being used. And again, semantic dementia, similarly, a focal temporal atrophy condition, so another cause of frontotemporal dementia. And it's important that you're clear about the terminology because patients and relatives, understandably, can get very confused. One minute they're being told the person has dementia, the next minute they're being told they have Pick's disease, then they're being told they have primary progressive aphasia, then they're being told that they have frontotemporal dementia. They're actually all the same condition with just different terminology being used. So you need to be clear about in your own mind. And going to the next slide, perhaps easier when subtypes are sort of known by what's causing them. Alcoholic dementia, pretty obvious what the cause is there. Dementia pugilistica, so repeated head injuries in boxing causing dementia, has long been recognised, but obviously in the last few years, and particularly sort of very high profile at the moment, is repeated head injuries from both soccer and from rugby injuries that's now known as CTE, or chronic traumatic encephalopathy. So another cause of dementia, probably underdiagnosed. Next slide. Again, sometimes it's by location. So frontotemporal dementia is pretty obvious. You're at the front and or the temporal lobes, otherwise known as Pick's disease, primary progressive aphasia, all the rest of it. Posterior cortical atrophy is the PET scan down on the bottom right. The arrows are pointing to the areas that haven't taken up much tracer. So the posterior, the back part of the brain, and the CT scan there showing atrophy towards the back of the brain there, predominantly on one side. So posterior cortical atrophy, again, a descriptive term. In nearly all cases of posterior cortical atrophy, the underlying pathology is Alzheimer's disease. And so, again, it's not a separate condition. It's a relatively unusual presentation of Alzheimer's disease. And next slide. And then finally, just the nature of pathology, Lewy body disease, Lewy body dementia. The Lewy body is the dark red circle right in the middle of that purple slide. So it's an intracellular collection of alpha-synuclein ubiquitin proteins. And that's what Dr. Lewy described, and is characteristic of Parkinson's disease and dementia with Lewy bodies. Normal pressure hydrocephalus is going to be a diagnosis made on imaging, and vascular dementia over on the right, again, a diagnosis that may be suggested by the history, but is really going to be confirmed by imaging, either showing single very large stroke, so post-stroke dementia, or lots of slightly smaller strokes, so multi-infarct dementia, or perhaps most commonly diffuse changes within the white matter. So the white areas on the scan indicated by the little arrows, which goes under lots of various titles, but the official terminology is subcortical ischemic vascular dementia. Dawn is just saying that the slides aren't coming up. Is everybody else able to see the slides? Or I should ask anybody else not able to see the slides? Yeah, I think it must be something at your end, Dawn. So
I Dawn, I would suggest if you leave the meeting and rejoin the meeting, you should catch up with the slides, and hopefully they'll advance for you then.
the wonders of Teams. Okay, next slide. Now, finally, just come back to Alzheimer's disease, which is going to be the commonest single pathology that's responsible for dementia. So if we call every person with dementia, if we say that it's Alzheimer's disease, we're actually going to be right more often than we're wrong. So about 50, 60, 70% of all cases of dementia are going to have Alzheimer's pathology. And Alzheimer's pathology is over on the left there, the amyloid plaque and the neurofibrillary tangle. They're actually Alzheimer's original drawings there. So the plaque, the brown stuff in the middle, that we now know is amyloid protein. The neurofibrillary tangle down the bottom is within the neurons there is the twisted tau protein. And these changes initially develop in most cases, not always, but most commonly they start in the medial temporal lobe, the hippocampus, in the green there. And amyloid tends to be deposited first, and then the amyloid deposits spread throughout the brain, and following the spread of amyloid, not far behind is the spread of the tau protein, neurofibrillary tangles. So the next slide, the current thinking is that Alzheimer's disease, initially there is deposits of what's being called A beta there, amyloid protein, and then that triggers the abnormal deposits of tau protein, and it's the abnormal tau proteins that then cause damage to the neuron, so the green line, so we have neurodegeneration, and then if we have neurodegeneration, that starts impacting on cognition and on function. So the importance of this cartoon is it makes the point that amyloid is being deposited in the brain for many years before it actually has any impact on memory or clinical function. So it raises the question of what we call what is Alzheimer's disease. Is Alzheimer's disease just the dementia stage in the right-hand part of the slide in grey there? Or does it include the MCI stage, which increasingly the terminology is prodromal Alzheimer's disease, the stage before it really becomes manifest? Or what about the stage before that, where there is the pathological changes, but not any clinical changes? So Alzheimer's disease, if we define it biologically, can be asymptomatic. It doesn't just have to have dementia. And the relevance, of course, is we want to prevent Alzheimer's disease progressing. Then the earlier we treat it, the better. And the next slide really is just showing the same thing in a different way. Most cases of Alzheimer's disease are sporadic, and there is a genetic component, this ApoE gene, and various other genes. Environmental factors, hypertension, age, of course, is the biggest single factor. In a fortunately, very small number of cases, Alzheimer's disease can be familial due to mutations in particular genes. And what happens is that amyloid accumulates, usually because it's not being cleared from the brain properly. And then that causes inflammation, tau, neuronal dysfunction, and dementia. And next slide. The importance of that is this is, in a way, the direction of travel in increasingly dementia, all dementias, particularly Alzheimer's disease, is being diagnosed biologically over on the left by biomarkers. So we already do scans, we already do CT scans, MRI scans that are obviously showing the loss of brain tissue, but we can get even better pictures of an idea of neuronal dysfunction by doing PET scans and measuring within cerebrospinal fluid the amount of tau. At the much earlier stages, we can actually measure the amount of tau or amyloid in the brain, either again by PET scan or measuring it in cerebrospinal fluid, or probably very, very soon, and it's already very much accepted at a research stage, measuring markers of amyloid and markers of tau protein within blood tests. So in about 5 to 10 years' time, everybody will be routinely taking blood tests and sending them off the lab to actually find out what the levels of these biomarkers are. And we're going to start making diagnoses based much more around biomarkers. But we're almost, but not quite at that stage at the moment. And that's just on the right, that's just to explain this terminology, which is the ATN terminology. A stands for amyloid, T stands for tau, and N stands for neurodegeneration. And if you're A positive, T positive, and N positive, then you have dementia or MCI. If you're just amyloid and tau positive, you may not have any neurodegeneration yet. And that's obviously a stage that we want to pick up, because that's potentially a stage at which things can be prevented. So that's the very early MCI stage. And then going back towards before then, we have the very first stages when people are completely asymptomatic, when they may well have amyloid in their brain, but none of the other consequences of it. And that's a stage which clearly things are potentially preventable. And so this trend towards brain health clinics and looking towards preventing dementia based around very much these very early stages. So last slide. Here we had the step 1, which was what's the syndrome. Step 2 is what's the likely underlying pathology, what's the subtype of dementia. And we'll go through all the little boxes over the next 3 sessions, but perhaps the take-home message is that identifying the subtype of dementia, the cause of the dementia, without having these biomarkers or without having pathological evidence is really just guesswork. And in the best hands, people are going to be right about 2/3 of the time. So it's important to try and think, well, what is the likely predominant subtype? Because that will help guide management. But we have to be clear that even in the best hands, even, dare I say it, in the the consultants' hands that we're waiting for them to confirm the diagnosis, they're going to be wrong 1 in 3 times. And so what we probably should be focusing on is identifying the syndrome as as well as we possibly can, and then making a best guess at what the subtype is, and then getting on with management. So this slide is going to sort of come up repeatedly over the next 2-3 weeks, and hopefully become pretty familiar to all of you. Any questions, any comments, any thoughts? Perhaps if we can have a break now, then let me just, can't see what the time is. Can anybody tell me what the time is?
20 to 3.
20 to 3. Okay, should we have a 10-minute break? And if we come back at 10 to 3, and then Raja, who I think I saw joined us, is going to talk a bit more about prevention. And I hope that's okay with you, Raja, if we just start 4 or 5 minutes late.
No problem. Yeah, that's fine. We'll start with
James has got his hand up, Tony. James has got his hand up.
As he hasn't on, don't know what's happening with Teams today because it's not up on mine. James, have you?
Yeah, it might be too much of a specific question at this point. It was more from a clinical point of view, obviously, with biochemical markers and things. Is there much literature about sensitivity, specificity? Because obviously it could have quite dramatic impacts on our clinical practice in years to come.
Yeah.
I assume it's a work in progress.
Yeah, there is. If you look at the literature, it's every second paper published on Alzheimer's disease at the moment is about specificity or sensitivity, and it obviously depends on the population you start with, because if you're using these tests in the general population, well then there aren't that many cases to pick up, whereas if you use them in a already diagnosed population, well, it's that much easier. So that's why they are at the moment treading water while everybody actually looks and does hone down much more on the specificity and sensitivity, so that we know exactly how useful they are. At the moment, it doesn't actually make that much difference whether somebody does or does not have amyloid, because we don't have an anti-amyloid treatment, but we may well have drugs that are licensed to treat amyloid in the pretty near future, at which point they do become very important. So the pharmaceutical industry has a great interest in getting the biomarkers to be, much more reliable and accurate. So that's, I think I said they're going to be routine in 5 to 10 years. They're going to be available within, well, they're already available and used, say, in North America and Australia. They'll probably be within, the next time NICE reports on dementia, they certainly will be within a few years. They'll be recommended then.
That's great. I just obviously there's a lot of literature and press about things like adalimumab and how that's going to change our funding options, I suppose.
Yeah, I don't think we have to worry too much about that because first of all, we have to see the evidence, then they have to get a license on this side of the Atlantic, and then they have to get NICE approval, and that's not going to happen within the next 2 or 3 years, but it is going to happen. Okay, see everybody in, I think, 7 or 8 minutes time now here. So I think, yeah, so we've got the majority of people back. So at which point, I'm not sure if, Roger, if you, would you prefer Sue to show your slides or for you to show them yourself?
If I can show it myself and change them, I think it's better, easier. I got it on my laptop now open. I don't know if I can share my.
Okay, if that's okay with Sue to give.
Yeah, that's fine. If you want to share your slides now, that should be absolutely fine.
Okay, so while we're getting the visuals sorted, Roger is a consultant psychiatrist in Aneurin, Bevan.
No, I'm in Comtaf, sorry. I've changed my health board.
Yeah, no, sorry. Yeah, that's my fault. Is recently moved to Comtaf and is going to focus and talk particularly on really preventing dementia and as I say, following on from all the opportunities around brain health and prevention, what we can do for ourselves, but more to the point, what we can tell to patients. Unfortunately, not particularly at the stage when they have already developed dementia, but stages before then. So, okay, so over to you.
Thank you, Professor Baer, for introducing me. As you said, I'm a psychiatrist, old age psychiatrist working in Comtaf. I've worked in different health boards, but currently I'm based in Comtaf. And I think this topic is very important as you would see a lot of patients who might have just MCI or sometimes it's not just about patient. And sometimes this question would be asked from you, from the relatives of the patient you're seeing that, what can I do to help myself or reduce my chances of getting cognitive impairment, dementia, or what can we do other than medication or other things that can help to improve the memory of my father or mother, whoever they come to see you with, patient who have got cognitive impairment. So I think it's important to understand that what can we do to promote brain health, because a lot of these things are quite basic and you can call them common sense, but we don't actually do them so often, and that can lead to worsening of cognitive impairment. So as I said, the objectives of this presentation or learning objectives are that we'll talk about the, as I said, the worried, well, the people who are anxious about getting dementia. That can be your patients, people who are coming to you worried. People who worked in memory team will tell you, you will sometimes get patients who will ask for referral themselves because their mother or father had dementia, and they'll be worrying about that, thinking that if they can have a check and see if they're well. And then they can be helped, by if you explain to them what are the risk increasing factor, what are the risk reducing factors. Patients who have mild cognitive impairment will also benefit from that. Then we'll talk about sensory and hearing losses, but I think because this is something which we miss, and I believe I'm still not doing as much as good work in that area as I should be. Then we'll talk about some lifestyle changes, and then we'll talk about some vascular risk factors, some diet and medications, and there are some medication which are associated with increasing your memory loss. So I think basically the message is that aging well will depend on several factors.
Roger,
Yeah.
I can't.
Hello.
I don't know about other people, but I can't see your slides.
Ooh. Can everybody see my slides? Oh, they disappeared. I can see them myself.
Okay, it's just me in that case. Can everybody apart from me see the slides?
Yes, I
Yes.
can.
Yes.
That's
No,
great. And then that case, carry on and ignore me.
okay. All right. So aging and health, I would say aging depends on a few factors. I think the three factors we say that genes, the environment, and your lifestyle. So there are things we can't change, but there are things we can change. So genes we obviously can't change. Environment we can modify up to an extent, but sometimes it's too late to do that as well. But lifestyle is something that we can certainly all work towards and changing. And don't think that if somebody hasn't been active all their life, how can they be at this stage of their life? I think there's always a chance that you can modify those factors. So I think the first thing I mentioned, I think this is something I've been doing memory clinic for now 9 or 10 years now, but I still think I miss this aspect because I training myself by reminding myself constantly that sensory loss is a very important important thing. That's something which we often don't check when we are assessing patients especially who are elderly. The research is telling us that 20% of adults and 75% of older adults have dual uh, uh, 20% of adults and 75% have dual vision and hearing loss. And the treatment is linked with an improved quality of their life. Is about checking their vision. Or if obviously we can't, when we are sitting in an outpatient clinic in a memory clinic, we won't be able to check the vision, but we can certainly recommend them that if or their carers that if you can take them for an eye test. When was the last time the eye test was done? Have they got the right glasses? Quite often you'll see patients who've been losing their glasses and nobody has bothered to replace them, or they didn't themselves bother to do that. So the skills, the things they can do, they will be losing that skill. Some people can develop cataract. There are other changes in the eyes that can happen, like diabetic neuropathy, and that hasn't been looked into. Same with the hearing loss as well. I can't tell you how many times that has happened to us, that that patients, which when you're doing their cognitive assessment, you can figure out that they can't hear you properly, they can't answer you, and they're scoring low on their cognitive test. But it's because they have hearing loss, sometimes as simple as wax in the ear which hasn't been cleaned, and uh, because of that, their cognition is appearing much lower than what it is actually is. So I think asking them or checking that if they had their eye test, or their hearing has been fine, or if they've been using the correct hearing aids, and all of those things can actually improve somebody's cognition and improve their understanding of their surroundings, and that can improve their cognition. Then the possible risk and threat to brain. I think this is something very important that you will see, especially not just for brain. It's also linked to your heart as well. Things like smoking, increasing your risk factors for heart attacks and also strokes, excessive use of alcohol, heart problem, diabetes, other health issues, poor diet, and I'll come to the diet in a minute, and insignificant sleep, lack of physical activity, lack of stimulation. All of that has been linked to uh, reducing your cognition and threats to brain, increasing your chances of getting cognitive impairment. So controlling those factors, trying to improve them. If somebody had heart problems, try and maximizing their treatment. If somebody has diabetes, controlling, having that diabetes control. Another heart problem, especially relating to high blood pressure, AF, and all that. That those all factor into threats to our brain. And where did that go? I don't know if you use this, but I used to say this a lot. Whatever is good for your heart is also good for your brain. I think the reason for that was because British Heart Association has done a very good work in highlighting problems, highlighting issues that can affect your heart, which is the same, like smoking, alcohol, that having high cholesterol, having high blood pressure, and all these factors can also help to improve your brain health as well, because they are kind of linked. so the actions we can take, or the actions that can actually help to improve our brain health. These are the recommendation I normally make to my patients, especially who have been diagnosed with MCI, or even who have been diagnosed with cognitive impairment as well. It's never too late to sort of try to protect your brain from certain things that we can control. Take care of your health. I would say that if uh, I will normally in my outpatient clinic, I'll ask them, if they have diabetes, when was the last time they had those diabetes checks? Have they been going to their GPs regularly? Have they been taking their medication regularly? If they are under a diabetes nurse, are they making sure that they are under constant monitoring? Because unfortunately, during the COVID time, I don't know if you noticed this yourself, the physical health monitoring was affected a lot. I think GPs got more and more busy, and the routine physical health checks were not happening. I think it is still, I still find patients who will tell me that their last physical health check was, I don't know, 3 years ago, 4 years ago, and after that nobody's contacted them, and they haven't themselves taken that action. So I think making sure that that's happening is important. Eating healthy food, keeping active, learning new things. I think learning new things is not for everybody, I would say. It's but if someone has particular hobbies, and I think I put it there because around, especially during the COVID time, people who were having quite regular hobbies or doing things quite regularly, they actually lost interest in doing them, and they were not happening anymore. So I think in that aspect, learning new things and new activities that could be done within your house, or using the technology, that was more relevant. Staying connected with your family and friends and community. I think that's something, again, this is very obvious, during the COVID crisis. Those of you who are working in memory clinics, you would obviously, you will confirm that, that how COVID lockdown affected the people who were not able to connect with their communities, with their friends and family. Their cognition, their physical health, their mental health declined just because of the fact that they were not allowed to go out, not allowed to meet with their families. Then I've already said about recommended health screenings, recommended following that, managing your health problem like diabetes, blood pressure, high cholesterol. AF is another factor which has to be controlled. A lot of patients, sometimes I have, when I check my pulse, patient's pulse, most of the patients who come to my clinic, I always check their pulse. I think it's one of the reasons is because sometimes we are prescribing them cholinesterase inhibitors like donepezil, and one of the things we need to do is make sure their pulse is running fine. Got a lot of times, I can't tell you the numbers, but I have found people having irregular pulse and they've never been diagnosed with AF, and then you write back to GP saying that they need to do an ECG and see if they have AF. And if they have AF, they need to on the medication for that. So having those basic health checks, things that you can easily pick up on, simple things as pulse, is very important. Then medication, I'll come to that in a minute, because as I mentioned earlier, there are quite a lot of medications. When somebody is elderly, they get prescribed a lot of medication. Quite a lot of times, medications are not required as well. They are extra prescriptions which were started and never reviewed and never checked, and they just continue taking them. And again, you will see a lot of patients in your clinic who will be on like 20 tablets in a day, and you will question that are they all required, really required, and how were they prescribed, when were they prescribed, has anybody been to review those medications? That is something I'll speak to you about, because a lot of giving wrong type of medication increase your risk of developing memory problems, falls, drowsiness. Quitting smoking is quite obvious one. So I mentioned earlier about the diet and how can we recommend patients about healthy eating, because patients will ask us about what can we do. I would say, like to say here, I'm sure people who have worked in memory clinic will tell you that you'll see patients who will say that since they develop memory problem, their diet habits have changed. And when I say change, they are not changed. Mostly they're not changed for good. They are almost always changed for worse. Like they started eating a lot of unhealthy food. They only eat chocolates or cakes, and all the things which will increase the weight, and they don't cook themselves meals, or they don't really feel like they have the concentration to make themselves salads and things like that. So I think making sure that patients are having a correct amount of food. correct amount of nutrients basically, and they're not just eating one type of food. Fruit and vegetables we all know are good for us. Whole grain meals. Um, Less, I think it's the less meat, but it's fish and poultry is important. Low fat or not fat dietary products, less solid fat, sugar and salt. Portion sizes are important. Adequate fluids are very important. I mean that's one of another factor. The fluid intake of elderly patients, it get less and less, and uh, it's something which we tend to ignore as well. That if they are not thirsty, why should they be drinking? Whether you will see that that I have seen patients myself. I'm sure if you working in the health sector, you will see patients who are in their homes and not getting adequate fluid. Sometimes even going into renal failures, acute renal failures, because they are not having enough fluids, and they don't have anybody to prompt them, or they don't have any mechanism where they can have adequate fluid. Nobody is actually monitoring that. So making sure that's happening. I mean, practically speaking, in my own clinic, I will when I have patients and their families, and they say, how can we ensure that my father or my mother who's got memory problem can eat healthy? I would say that, if the fruits are visible to them, if they're in front of them, they will eat. If they are sitting in front of TV, if you put a selection of food in front of them, they will pick up, start eating that. Same with the fluids as well. If the fluids are in front of them, they can see the visual prompt for them, that will help them to actually prompt it, and then they might start drinking or eating that. So then there are some practical things you can do. Otherwise, referral to dietitians sort of also help as well, because they can have a look at the whole picture, and then they can help you improve that. Now, physical activity, I think this is one of the things I think I would say you will find that when patients are getting older, and not just the ones who are developing cognitive impairment, the patients who are generally getting older, they'll start getting more and more isolated in the home environment, and reduce activity of going out. Simple things like they used to go out on shopping trips to the supermarket, and that supermarket trip would have cost them 20 minutes of walk or 30 minutes of walk within supermarket. But now they don't do it because their son or daughter is doing it. They just think they will get extra confused and they can't do it anymore. So this is just a simple example, but can give it. You can come up with a lot of other examples that families who are worried about their loved ones, they will start doing things for them. It's part of, they from their point of view, they're showing love and they're doing them a favor, but they're reducing their physical activity. And we know that reducing physical activity, they increase your risk of diabetes, heart problems, you increase your weight, depression, stroke, and all that. And if you start losing your muscles in your legs, and your strength in your leg, that can lead to you becoming unsteady on your feet, and then risk of fall. So the recommended thing is that you should have 150 minutes of exercise each week. Now, exercise could be as simple as walking around, um, going around on walks with your family. If you can't, if somebody has a dog, walking their dogs will also count. I think this is something which I always encourage for my patients and their carers when they come to my clinic, that we need to find ways to make them more active. How can we take them out of the house more often? If there are any day centers and there are any activities happening in the community that they like to go and enjoy, that is one of the other things. But even simple things, as I mentioned, taking them to a shopping center, taking them to get a cup of coffee, taking them to a walk in a supermarket, though all those things can actually improve your physical activity. There are some programs as well around walking, and and to move more safely. If you can find, especially through the third sector in your area, that will help as well your patients. Now, how do you keep your mind active? That's something a lot of patients will ask you, or their relatives will ask you. So I think mentally stimulating activities are the recommended things in that area. now everybody will have different choices. If somebody is known to read books, then you can encourage them to read books. But you will find patients who never read book and never like doing that. Um, but if they like doing that, reading books, magazine, reading newspapers, simple things as doing the crossword, playing those games which stimulate your mind. I mean, nowadays, in the past, we used to encourage people who were doing patients, older patients who were quite used to doing crosswords and things like that on the newspaper. So they will like the newspaper to be given to them in their house, and they should read them and do those crosswords on the games on that. But with the modern technology, if they have an iPad, things like that, they can do that on it as well. Obviously, not all patients like that. They might not be able to uh, learn it. It can become a new skill for them to learn. Taking classes, and these sort of things are around attending day centers and activities in the community through social work and social worker and volunteering. And I think this is an important thing I like to mention. If you're working with a memory clinic, or I think it just goes for any mental health service, not just for memory clinic, we always need to be aware of what's happening in our community wherever we are working, so we can make those recommendations, because all the treatment for mental health is not just biological. It's not just about prescribing medication. It is social intervention. It is psychological interventions as well. So whenever I've started a new job or gone to a new area, I always ask my staff, tell me what is happening around here. Is there any leaflets? Is there any activities, any social activities, any group activities, what is the third sector doing in our area? I mean, if I have a magic wand, I like to do one change in mental health services. This is what I'll do. I'll make third sector and our mental health services work more closely together, because we we want the best for our patients, both of us, but we work in a different universe. We don't actually communicate with each other. You will find a lot of the times the third sector are doing some amazing work within your area, but you won't know about it. They won't tell you. And only sometimes I find out from my own patients that they will come and tell me that I go and attend that particular group, I go and attend this activity is run by mine, is run by that particular charity. And you say, well, if I wish I knew about that, because I would have other patients I can refer to them. I think having those connection with the third sector, knowing what are they doing in your area and referring patients to them, I think that's very, very important in terms of making your patients more physically active and also mentally active as well. Stay connected. I think this is a part of your social connections. I think patients who have meaningful activities like volunteering, there's evidence that they feel much happier and healthier in their life. Social activities are linked to reduced risk of some health problem, including cognitive impairment. So again, as I mentioned already, volunteering could be done by a third sector. They do a lot of good work in that sense. I have patients who started volunteering after they were diagnosed with cognitive impairment. Things like, I have my patients going in and standing or serving in a charity shop, and they used to absolutely love it, because it give them a meaningful activity. They're doing it under supervision. They're doing it with somebody who knows their condition, but they will really love to interact with other human beings, and they will love to interact with the staff there. Those sort of things are useful. um, and I think the other thing I've already mentioned about understanding what's happening in your local area and agencies are doing what. Community connectors. I don't know if I'm sure you must be aware of a service called Community Connectors. This was when I was working in Anand, when we were using them quite a lot. Community Connectors' main role was that they, as I said, they had the connections and they have the information of what's actually happening in your community. So we used to make a referral to them saying that, I got a patient who like to be more active, who like to have more social stimulation, psychological stimulation. What can they do? So that one of the community connector worker will actually contact them via the phone, or go to their house and connect them and speak to them about their interests. And then they will have a list of things which is happening in the community and try to link them up with that particular activity. So that was, I thought that was very useful for my patients. So medications, I think this is the last part of the presentation, but I just wanted to say, if you are working in memory clinic, you will come across patients who will be prescribed a lot of medications. And I think it's nobody's fault. I think they have conditions which are other physical health conditions, but when they are getting those medications prescribed, there's a class of medication in particular called anticholinergic medication. They block the action of acetylcholine, and we know that acetylcholine is a very important chemical in our brain, and that is lack of that can lead to patients becoming confused. And in Alzheimer's dementia, that's the main problem. They have lack of acetylcholine, and the medication we are using, the cholinesterase inhibitors, uh, donepezil, rivastigmine, they are actually doing the opposite of that. They are trying to increase the level of acetylcholine in the brain. So anticholinergic can be used in certain conditions like urinary incontinence, overactive bladder, chronic COPD, Parkinson's symptoms. It is helpful in Parkinson's symptoms as well. Gastrointestinal GI symptoms. Patients who are having IBS, things like that. They have been prescribed in that. The problem is anticholinergic medication is they will make your patients confused. And they will appear more confused than they actually are if they are on these medications. And changing those medications, giving them the alternatives, and they are sometimes quite good alternatives as well, can improve their outlook. So identifying them, it can become a challenge for even for a psychiatrist as well. Even as a doctors, we don't actually do this so often so well. Sometimes I ask for help from our pharmacist to see if there are any medication which we can stop and have to um, or ask the GPs that if their anticholinergic burden can be reduced. So this is a list of medication, the general list, but I think you will see I am a doctor. I've been working in psychiatry for such a long time, but I won't be able to remember all of them. I'm just giving this list as an example. But the reason I was going to show you this skin is because a lot of these medications you will find are prescribed in mental health anyway for other reasons. Like amitriptyline is prescribed quite commonly for pain in the nighttime. Quite commonly, GPs will prescribe that. Sometimes GPs prescribe it for sleep as well. And it is actually doing the opposite effect for us. It is making patients more confused. And then there's some other medication you identify, olanzapine and antipsychotics as well in this list. So this is a useful tool. I don't know how many of you have actually used it, but I started using it 4 or 5 years ago, I think, when it came out. It's called an anticholinergic burden calculator. So all you need to do is you need to type the name of the medication patient is on. If you're not sure which medication is actually anticholinergic, which is not, and then if you put the list of if the list of patients medication in this calculator, it will tell you that what is their ACB score, and it will tell you that if the score is too high, that means that they are taking too many anticholinergic medication, and that may be affecting their cognition, that may be making them more confused than they actually are. So obviously in that case, if I actually find a patient like that, I will write back to GP and say that we have identified these medications can make patients more confused. Is there a possibility that you can review them and see if there are any alternatives? Sometimes, as I said, sometimes these medications are prescribed long term and nobody has actually reviewed them. And by prompting that to the GP, they might review them and then they might stop them. So in summary, I think I just want to say that the message we give our patients and the message for our staff as well is the physical and mental health are quite interlinked. And if you have good physical health, your mental health will improve. I think this is a message generally for mental health. It's not just for patients with memory problems. As I said, if you are assessing somebody for their memory loss, always think about sensory loss. This is something which can be in some cases reversed, and by reversing that, you can actually improve their orientation, you can improve their attention and concentration span. You can always improve sometimes in some cases improve their memory as well. And as I also said, social stimulation, we as health professionals may feel that my role is only medical, so I can only do medication or I can only do things which are related to medical bit of it, and social stimulation is responsibility of social worker or third sector, and they should be doing. I think, but for when you're treating somebody with any mental health condition, you have to think biologically, psychologically, and socially. And sometimes the main intervention which is required, the main intervention that will help to improve the quality of a life of a patient or the carers is social stimulation. So having those links, finding those links, speaking to your social workers, your local social services, finding out what's happening in the third sector in your local area, that will help you and help your patients as well. And as in thing, last thing was the polypharmacy, thinking about polypharmacy, and then see if we can reduce that. And I think some doctors, some GPs are pretty good at it nowadays. I've seen they will be quick on that, reducing unnecessary medication. But then still, you will find to this day you will find patients who are on 20 medication in the morning and 30 in the night, and you think, even you will be thinking, how do they really need all of that, and how is this affecting their memory? How is it affecting their cognition or physical health? Are these medication doing any good for them anymore, or they're actually their side effects are actually worse than their benefits? So that was it. Thank you for listening to me. And if there's any questions, I'm happy to take that. Let me just.
That's great. Any questions or observations or experiences that people want to flag up? Is anybody that sort of involved in running brain health or prevention type clinics locally? Because that seems to be the up and coming thing. Lisa, I think I can see you've got your hand up.
She's frozen for some reason. No, she's good. She's back now.
No, Lisa, you're alive again with us. So you've got your hand up, but you're on mute. You're on mute.
There we are, I'm back now. Yeah, can you hear me?
Yep, perfect.
I just wanted to say about the ABC calculator, really. I've just undertaken a course within assessment of older adults in regards to their physical health, and I'm actually doing a presentation on the ABC calculator, and I just think this is vitally important for this to be utilised within the GP practices and for sort of CMHTs to sort of include within their assessments when they first come into the service. So I'm hoping to sort of disseminate that within our area, because I think that for our patients and the amount of medications that they are on can have massive adverse effects, which we're picking up quite a bit within our service at the moment.
And I think the brain health clinic, I was going to say that.
I've frozen again, have I? Oh.
No, we can hear you now. Yeah. Sorry, the last sentence was broken.
Oh, right, okay. Sorry, it's just for as a community psychiatric nurse on initial assessment, I think it's quite a good a tool to we could use that widespread within our service, really.
No, I think Raja's frozen. If I can just say what is totally illogical is for people to be started on cholinergic drugs, so drugs like donepezil, galantamine, and be taking anticholinergic drugs, as Raja mentioned, at the same time, because you've got the worst of both worlds there. You've got each drug competing with its opponent. So certainly anybody who is on donepezil or is being considered to start donepezil, thinking about anticholinergic burden at that time is critically important.
I think so, yeah, to you know, facilitate that in our practice and you know, pop it in as an assessment tool prior to the commencement of these drugs.
And I think sometimes it is difficult to stop them as well, because if we'll have to rely. I think that's what I felt, that we have to rely on the GPs to review that again. Sometimes if the patients are in Parkinson clinic, they are under Parkinson clinic, so they are under another specialist clinic. Sometimes we have to write back to them and say that is there any alternatives? And there are alternatives, you know, that can be given. And as you said, you know, a lot of the times these drugs are started and patients have been taking them for years, and they themselves don't know why they were started and why are they on the list. So it is vitally important that we assess them, and we are not good at it. To be honest with you, I myself trying to tell myself that you need to do this more often.
Yeah.
The difficulty
Just
is
be mindful, I think, within practice.
Yeah, and it's no one person's clear responsibility. You know, it's not clearly the GP's responsibility. It's not clearly, you know, which means that people fall through the cracks. So if it's not one person's responsibility, that's a good reason for every patient you see for it to become your responsibility. And it's very, it's got the major feel good factor about it, because you feel that you're actively doing something. And you're not every patient, but quite often patients will actually say how much clearer thinking they are having stopped, and they'll be happy because they're taking this medication. So it really is useful for everybody. Okay, any other queries, comments? No. In that case, if I can thank Raja very much. Most people, if you're back and you still have your hand raised, can you lower it? And then we'll know that you're here. Yep, okay, so that means everybody is here. Okay, so let's go for the last session, which is a bit more practical. The first thing is the keen-eyed of you will realise I'm not Rachel Brewer, but Rachel previously had my slides, and so I'm afraid I forgot to change the names, but never mind. So thinking about history and your brief cognitive tests. And that's really what's going to tell us whether somebody has dementia or not. We don't need anything more than that. You know, all we need to know is, you know, is somebody concerned that there's been a change in their cognition? Is it, how are they functioning? Has there been a change in function? How long has it been going on for? And then a brief cognitive test to see whether they do or do not have any evidence of cognitive impairment. And so that really is going to tell us whether somebody has dementia. If we go to the next slide, okay, so that's going to tell us what the syndrome is, and then within that history and doing the cognitive test is going to be giving us clues as to what is perhaps the more or less likely cause of the syndrome. So it's not rocket science. Now, a lot of what I'm going to say is sort of, I know, personal experience, anecdote. If everybody else has got sort of things that they find useful in, you know, getting a history, doing tests, sort of chip in, because the more, you know, experience, the more skill we have at it, the easier it gets. Next slide. Thinking about what we want to get from the history, and this is just, you know, again, personal experience. I sort of assuming if I see somebody in, you know, a memory clinic or somebody who presents with possible dementia or cognitive impairment, I'm going to want to get their version of events. I'm also going to want to get an informant's version, somebody who knows them well. So usually it's going to be relative. Ideally, it's useful, I find, to see them more or less at the same time, for lots of reasons. But one of the things I have found is useful is to actually go out of my way to get the patient to do the talking first. And then you can have the informant version to sort of back it up or contradict it or whatever. So the way I used to set up the memory clinic, if I was seeing somebody, instead of asking people to wait in the corridor or having sort of whispered conversations with one side or other, with the other side wondering what was being said, I found it was much easier to actually see the patient and the informant together, but to go out of my way to actually make sure it was the patient who was initially the focus of things and who I would be initially get the history from. And sometimes that meant me almost having to cut across the overeager daughter or or husband who's used to doing all the answering, and I'd have I'd position things so that I would tended to be sitting next to the patient, and the informant was sort of more out of my field of view. I can sort of get eye-to-eye contact and address the initial questions to the patient, perhaps explaining first to the relative, well, I'll let you, I'd certainly be interested in hearing, and I want to hear your account of things and your concerns, but perhaps initially first I can just ask your mother or your wife. And sometimes quite often you can feel the impatience and the irritation coming from the relative, and sometimes even as far as, well, there's no point in asking her because she's unreliable or that's not true or whatever, and just saying, well, yes, but let me just ask your mother first before I ask you. Having sort of got the patient's version of events, you can then go to the informant again, sometimes with an apology. I'm sorry that I'm sorry if you thought I was a bit blunt, but I was keen to hear your mother's concerns first. Now you tell me, and with the apology, even if the relative has actually got a bit shirty because people weren't listening to her first, it's then okay. The problem is, immediately you get the informant's version first, that colours your thinking. It also means that you often never get as far as getting the patient's version because they're just going to repeat what was said or go along with it. We're interested in who is most concerned. Is it patient? Is it informant? If it's the patient, then this is obviously, I'm generalizing now, but perhaps it's less likely that they're going to have dementia because characteristic of many dementias is you tend to lose insight and awareness. If it is the patient who's making all the running and the relatives are tending to play it down, perhaps that's less likely it's dementia. We're going back to thinking about one of the things we want to find is the timescale of things. So focusing very much on when was the first change that you noticed. And again, they're perhaps very keen to talk about this instance when I know they couldn't remember where the car was parked in the car park, and then there was a whole load of fuss about having to get the security people from Tesco's to come out. You get this very long-winded story, which is relevant, but importantly was that, have you noticed any problems before then? What was the very first, thinking back now with the benefit of hindsight, what do you think was the very first change that you noticed? And often say, oh, well, they haven't been quite themselves for the last 2 or 3 years, but it was only last month that so and so and so and so on. So you really want to pin down the timing of the first change, and then what's happened since then. Has it just steadily got worse? Has it fluctuated? So on and so on. The other thing is to perhaps, rather than use these generalities about they've become very forgetful and they were very confused and they often, I won't allow them in the kitchen because they now have problems, get specific examples. Or what, can you think of a specific example of something they've forgotten? When, so you're saying they often, you won't let them out now on their own because you're concerned they will get lost. Well, have they got lost? What happened? What were the circumstances? So rather than generalities, specific examples of what the problem was. Okay, then next slide. Again, what we're particularly interested in looking for change in that MCI dementia is a change from a previous state. A challenge often is perhaps somebody who has never been had that much education, hasn't been perhaps intellectually the sharpest. It's difficult to tell whether this is their normal state or whether it's something new. So, how long have the problems been going on? What has changed? And this just happens to be there are a number of papers that looked at the things that are best indicators. This just happens to be one that we wrote a few years ago, and this is based on, let me think, this is based on, yes, Caerphilly population. There was a large medical research council study conducted in Caerphilly over the last 30, 40 years. And about 20 years ago, we looked for cases of, started looking for cases of dementia and MCI. And we had the advantage that we had history going back 20 years before then, because the study started in the 1980s. And so we could go back and look for changes that were most predictive of dementia. And this is in rank order, I think, from memory, I think there were about 180 different symptoms that we had listed, and the top 5, 6, or however many it is here, 6 here, the problems with planning and judgment, uncharacteristic challenge, they were very predictive of that. So again, there isn't much here about memory. It's other factors, misjudging something, perhaps a slight social profile, planning something out and then it all going wrong. That was very predictive. Having problems with finances, people, it is something we commonly ask, people taking over responsibility for sort of handling financial affairs or helping with bills. Problems learning new gadgets. Again, this was a study that was done in the 1990s, early 2000s, and people having problems with TV remotes and never mastering a mobile phone was very common problem then. I think probably still is, but obviously is going to get less and less as people become familiar with it. Managing medication, and so this is something certainly that I often feel could easily be picked up within the pharmacy or within general practice when people aren't actually collecting their routine medication. If they're having prescriptions issued every 28 days and then they suddenly stop regularly collecting them, one should be asking why. And that's a pretty good marker. Obviously, the driving skills are something I think we're all alert to, and then loss of interest in activities. So those are, if there are going to be sort of 6 areas in functioning that it's worth probing and asking about, those are the 6 that in our study and other studies tend to be most sensitive to picking up signs of dementia. Next slide. This, I don't know, is anybody familiar with this, the AD8 assessment?
No.
Anybody want to put their hand up if they are familiar with it, or I'll take silence as a no? Yeah, it's surprising. It's been around for quite a few years. Well, 2005 was published there, and there are a couple of areas that are very enthusiastic about it, but generally it's never really caught on. And it's surprising to me because it was as good, and other studies have shown it's as good a quick screen for dementia as all the other brief cognitive tests. If you want to actually get a population and you want to see, screen, has this person potentially got dementia, it's actually better than the old mini mental state for picking up people with dementia. And again, it's hopefully you can read it because your eyesight is better than mine. Put my glasses on, I can probably read it. Yes. It's again, interestingly, it's the same sort of list as on the previous slide. So top is problems with, do you have problems with judgment, and then loss of interest in everyday activities and so on. And the way you administer it is just administered to somebody who knows the patient well, and you just actually asking them, have they noticed any change in the last few years caused by problems with thinking and memory, any change in thinking, in having problems with judgment, for example, problems making decisions or financial decisions, or problems with thinking. And people simply have to say, yes, I have noticed a change, or no, definitely not, or oh, I don't know, maybe this, that, and the other. So they don't have to deliberate for long. They can say, the not applicable, or I don't know option. And if people actually score, it's out of 8, 0, or they just score the yes being a change being 1 point. If you score more than 1, so 2 or more, then it's highly likely that person has cognitive impairment. So I'm not suggesting that people should sort of start adopting it routinely or anything like that, but it is something worth you knowing about. And if you're being asked to you screen population, well, then it is certainly it's a sort of good. We talk about sensitivity and specificity of biomarkers before. Its sensitivity and specificity for dementia is certainly better than any of the biomarkers we've got at the moment. So that's the AD8, and there'll be a copy on the Padlet if anybody is interested. The big advantage too is the fact that it's copyright free, and you don't have to pay for it, and you can photocopy it, and it's not rocket science to remember the scoring. Okay, next slide. Once, what we want to do is sort of decide whether, say, step 1, is there evidence that the person has dementia or some other syndrome? And then if they do have dementia, we need to think, well, what markers that might make us think that it's one pathology, Alzheimer's disease, rather than another. So this is perhaps a fairly typical history. Lady being seen at the request of her daughter. She denies any problems, but when pushed, she admits her memory isn't as good as it used to do, but then immediately attributes that to old age. The daughter gives a history that's gradual development over about 2 years. Again, when pressed for specific examples, well, she can't remember names of children, particular names of grandchildren. She got mixed up phone numbers on 2 occasions recently. Went out in gone shopping. She temporarily got a bit disorientated and lost. She'd put food in the oven, forgotten about it, and so triggered the smoke alarm, and so the neighbours had to come in to help her turn it off. Stopped doing a daily crossword. She's concerned that the bills may or may not have been paid, and but is a bit grudging about whether the daughter should or should not take over. Now, I think hopefully we'd all agree that's a pretty typical picture. Would anybody say that she has dementia or she doesn't have dementia and make their case?
Perhaps she's got some sensory impairment.
Well, you mean she does have some sensory impairment, or you want to know if she has?
Want to know if she has, first of all.
Absolutely, and we'll say she's got actually perfect eyesight and perfect hearing.
Has she got acute
for the sake
infection?
of argument, for the sake of argument, we'll say that every single other question you can think of to ask, the answer is no.
Okay.
So on the basis of what we've got there, who thinks she's got dementia and why? I can see I'm going to have to start picking people off, aren't I? Has she got any history of cognitive problems? Yes, because she's she grudgingly admits her memory's not so good, and the daughter says fairly clearly that the memory is getting worse. Are those cognitive problems impacting on function? Well, yes, because she's got lost. She's can't fix the fire alarm and all the rest of it. And for the sake of argument, we'll say that she scores under some cutoff on a simple cognitive screen. So there's no great argument about the fact that she has dementia. And let me put the chat on so as I can see. So Elsa's saying, I'd say it's likely. In practice, you'd need lots more information. Yeah, there's. I say if we assume that there isn't any more information to find, she has got cognitive impairment, she has got functional impairment. There is a change. She's otherwise fully alert, and it's developed over 2 years. So actually, there is no argument about the fact that she has dementia. And frankly, you don't need anybody to go and sort of confirm it one way or the other. It's cut and dried. Next stage is what is the likely underlying biology? Is it Alzheimer's disease, vascular dementia, whatever? Now, if we go to the next slide, statistically, it's going to be Alzheimer's disease. So often, probably the sensible thing is to in a way think, well, is there any reason why this is not going to be Alzheimer's disease? Are there any pointers that suggest that it's not Alzheimer's disease? And these are, again, the typical symptoms that are most associated with Alzheimer's pathology. So Alzheimer's pathology, the amyloid plaques and the tangles of tau protein typically those pathological changes start in the medial temporal lobe and the hippocampus. And the hippocampus and the medial temporal lobe very broadly are involved with learning new information and storing memories. So therefore, typically people with Alzheimer's disease are going to have prominent memory problems. And that's what this lady is, her daughter is concerned about her memory and giving examples of forgetting names or whatever. Typically, people with Alzheimer's disease, especially as their dementia progresses, tend to be lack insight and a bit resentful or indifferent to the problems. Everybody else is concerned. In this case, it's the daughter who has brought her to for diagnosis. It's not the lady herself, and often the patients will tend to just give some justification for why they make a slip, or you wouldn't expect me, or I don't keep up with the news these days, or since my retirement I haven't had to think what date or day of the week it is, which it has to be said is true. I'm much more sympathetic now to patients who don't know the day of the week than I used to be, because my weekends are not as clearly distinct from my weekdays. And so I'd suggest that you shouldn't actually put so much weight on asking people a day of the week. Do you know what the head turning sign is? Not can be the obvious.
Relative for their answer.
Can't hear you, Jane.
Is it when they look to their relative for the answer if they're asked a question?
Here, absolutely. Here we are in the clinic and we've got the patient sitting next to me and I've got good eye contact with them and I ask them the question and they immediately look to their left and for their relative to answer, and the relative often starts answering for them. We're all familiar with it, and if you're not familiar with it, if you start actually looking for it, it's very, very common. And interesting, there's a study that shows that actually that is pretty highly correlated with the severity of Alzheimer's pathology and biomarkers. The more amyloid in your brain, the more likely you are to have a positive head turning sign. So it sounds trivial, but it's a pretty good marker of Alzheimer's disease. Getting, again, medial temporal lobe and hippocampus are involved with topographical memory, remembering where we are, sort of managing maps. So route finding, getting lost in familiar surroundings, common, and then social withdrawal, the difficulty with new technology, I got a new mobile phone 2 or 3 weeks ago, and I've had to get 2 of my children to go through it with me again, just so that I can keep up with the new technology. But hopefully now I've learnt, it will stick with me. If they have to carry on telling me every week or two what to do, well then I've got more problems than I think, and obviously I do have lack of insight, and then losing previous skills. So they're pointers to Alzheimer's disease. So going back to the lady in the previous slide, she actually ticks most of those. So we actually, that lady is giving a sort of pretty textbook diagnosis or suggestion that the underlying pathology is going to be